Hi everyone, and welcome to the part 3 in the 3-part series where we've been discussing moving, handling, and positioning of the surgical patient. So in this third and final section, we are going to talk about positioning such as lithotomy. We'll also go over modified Fowler's, lateral, prone, the jackknife position, and we'll talk about the spinal table and the orthopedic table. So let's get started. All right, so the first position on our list is the lithotomy position. And as you can see from these 3 images here, there are a variety of different types of stirrups that we can use. Now, the top 2 images, the book refers to these types of stirrups as knee crutches. The yellow ones that you see are referred to as the Allen stirrups. That's a specific brand. And then the ones on the upper right, I would refer to those as like a well leg holder, but they can also be used for positioning in the lithotomy position as well. And then at the bottom, you see what we call the cane stirrups, or sometimes you might hear them called candy canes because they look like the shape of a candy cane. So, when do we use the lithotomy position? The lithotomy position is used for some GYN, genitourinary, and rectal procedures. So, such procedures like a D&C, vaginal hysterectomy, Bartholin's cyst, cystoscopy, bladder biopsy, transurethral resection of the prostate, potentially sigmoidoscopies, hemorrhoidectomies. Those are some of the main ones. If the patient has a rectal fistula, we might also use this position as well. I talked about the different types of stirrups. So when we are positioning a patient in lithotomy, it is a type of modified supine, all right? And so we're going to first put the patient into supine, and then we're going to get them into the lithotomy position. Now, it's best if we have 2 to 4 people that are helping us with this position. So, before the patient comes in, what they're typically going to do is take that headpiece from the OR table and bring it down to the foot. So now when the patient moves over onto the bed and they have to scoot their bottom down so that it's at the edge of the break of the table, anesthesia won't have to lean over a foot to try to intubate the patient during induction and intubation. So we're typically going to do that before they come in and put the stirrup on the side opposite of where we're going to bring them in. We'll have that one already there and positioned. Then that way, once we move the gurney away and the patient is put to sleep and anesthesia gives the okay, we can go ahead and put the other stirrup on, and then we can get going with the lithotomy positioning. So once the patient is positioned in the supine position, there's 1 of 2 ways that they can do the arms. One, they can put them out on the arm boards, and we want to make sure that the arms are positioned at 90 degrees or less from the body, or they're going to tuck the arms. And you can see in this top image with the yellow Allen stirrups that the arms are down to the side. This can increase the chance of a crushing injury because we do bring that bottom of the bed all the way down, like you see in the image on the top right. So if the fingers are there, when we're done and we're bringing the bottom of that table up, we could trap the fingers in there. So we always want to be sure we know where the fingers are if they are tucked down by the sides. So one of two ways, out on arm boards or tucked by the sides. All right, once the anesthesia care provider gives us the okay and the stirrups are in position, we need one person for each leg. And the legs are going to be raised simultaneously, all right, and put into the stirrups. And we want to make sure that there's adequate padding. The hips are going to be flexed and the legs are going to be abducted at approximately 30 to 45 degrees. And the knees are going to be flexed at 80 to 100 degrees. We're going to try to keep them in a parallel position if we can. Once each leg is secured into the stirrups, that is when we're going to lower the bottom of the table all the way down. Now, some tables, that lower part of the bed does completely come away from the bed, so it just depends on what type of table you're using. We want to make sure when we're moving the patient into the lithotomy position that we do it very slowly. That way we can help to prevent sudden shifts in blood pressure or reduce the chance of hip or spinal injury. When we're using the candy canes, we want to make sure that that stirrup isn't putting pressure on the Achilles tendon. Also want to make sure that the bottom of the foot is padded well. Usually these are disposable little stirrups, little foot holders that we use. So those will be discarded at the end of the case. We also want to make sure that if we're using the candy canes, that the legs are not resting against the metal of the candy cane. So these can be manipulated, turned, raised, lowered, whatever. If there's nothing that we can do to get that leg from resting against the candy cane, then we need to put some sort of padding between the stirrup and the patient's leg. Now, at the end of surgery, we need to make sure we know where the fingers are, and then we're going to put the bottom of the bed up, or we're going to reattach the bottom of the bed. We need one person for each leg to bring the patient out of lithotomy. And you want to make sure that you get the green light from the anesthesia care provider before you start moving the patient. So once anesthesia is okay that you move the patient, then simultaneously 2 people will remove the straps and then slowly bring the knees together and then gradually and slowly lower the legs back down to the bed. Now, the book does say that the safety strap should be put on the patient, but it's very difficult to put the safety strap on the legs 2 inches above the knees. You can probably see that from looking at the positions in each of these images. Sometimes they will put it across the abdomen. Okay, so that is pretty much lithotomy in a nutshell. I hope that helps. All right, next we're going to talk about modified Fowler. You might also hear it referred to as the beach chair position. If you think about lounging by the pool or on the beach in a beach chair, it's kind of that kicked back. You know, your back is up a bit and your legs are a little bit bent, knees are a little bit bent, and you're just kind of sitting there nice and comfy. That's where it gets its name from. All right, so Fowler, which is sitting or semi-sitting, may also be referred to as the beach chair. So the back is going to be nearly vertical and the knees are going to be flexed, and sometimes they will tip the table back just a little bit, slightly into Trendelenburg. This position is typically used for cranial and cervical spine surgery. It can also be used for breast reconstruction surgery, shoulder surgery, and sometimes when they are doing tonsillectomies on the adult patient. Now, if we're doing something like shoulder surgery or spine surgery, there's going to be additional positioning devices we need just besides manipulating the bed. And so we're going to need to anticipate that and prepare for that before the patient comes into the room. It's suggested that we have at least 2 to 3 people for this position. So first, we're going to start with the patient in the supine position, and then the upper table section is going to be placed vertically, and the lower section is going to be flexed downwards, and this should be near about where the knees are. So the knees are going to be slightly bent, and we should put pillows under the knees, under the calves, under the heels, and at the feet. There should also be a padded footboard. We don't want any compression injuries, so we want to make sure we pad all of those areas really well. The safety strap is going to still be placed a couple inches above the knees. You can see that there in the image. And then the head might be placed, if it's a cranial procedure or a spine procedure, it may be placed in the Mayfield, like you see these tongs here. It may also be placed in some sort of head cradle that kind of straps the patient's head in. One thing that we kind of all want to get our eyes on is the cervical spine in alignment, right? It's always good. We're probably going to be near the foot of the patient. So if you are, and you are setting up your case, it's always good just to kind of give a little bit of a peek when they're asking, hey, you know, does the positioning look okay? Does the alignment look okay? Get your eyes on it too, so that you can also, you know, see the alignment or verify the alignment, whatever. More people looking, the better. Alrighty. The arms. Now, if we're doing shoulder surgery, one arm is the affected arm, and we're going to leave that free. And I have a picture coming up on the next slide that will help us get a better visual of what the positioning might look like for shoulder surgery. But if we're not doing shoulder surgery, the arms may be either strapped in place, or there may be some like arm holders, little rests that can attach to the bed. You know, then the arms could be fastened there with a strap, and some padding or gel pads can be used to protect the arms. All right, so I just wanted to give you a couple other images to look at. The one on the left, this is the beach chair position. It's a special shoulder positioner that attaches to the bed itself. And you can see how her head is resting in this head cradle, and it's strapped across the forehead and under the chin. A lot of times they will put some little eye goggles on the patient too, so that their eyes don't get damaged. And then you can see the arm holder on the right side, on the patient's right arm. Now let's look at the other images. Again, for shoulder surgery, you can see that the top two images are the Fowler's or beach chair position. The bottom one is lateral, but what I wanted to show you on the bottom right is how they have extended this arm out. And a lot of times when we're doing shoulders, they'll want to put traction on that joint, basically. So it's going to open up the joint space. And so there may be some sort of traction device that we're using in addition to the beach chair positioning device. Next on our list to discuss is lateral decubitus position. Sometimes you might hear it called the side lying position. You might also hear it called the Sims position, S-I-M-S, Sims position. Anytime you hear lateral, side lying, or Sims, talking about the same thing, all right? So what's the goal? The goal of the lateral decubitus position is to expose the flank and lateral thorax, as well as the lateral aspect of the hip, knee, and ankle. All right, that whole lateral aspect of the body. Could also be shoulder. Sometimes we do like labrum repairs in the lateral position. So any surgery where we need access to the side of the patient, okay? And something important to note is that when we describe the lateral position, whatever side is named the downside is the non-operative side. That's the side that's going to rest against the table. So if we are looking at this patient, the right side is up and the left side is down. So this is going to be left lateral decubitus position. All right, so the side that is in contact with the table, that is how we are going to describe it. So how many people do we need? Well, best case scenario, we should have 4 to 6 people, depending on the patient's BMI. Now, let's talk about how we get the patient into the lateral position. First, the anesthesia care provider is going to anesthetize the patient in the supine position, and then once anesthesia gives the A-OK, then we're going to proceed to get the patient into the lateral position after the airway has been secured and after the anesthesia care provider has given us the green light. One person's going to be responsible for the lower legs and feet, one person's going to be responsible for the pelvis, and one person's going to be responsible for the thorax, which includes the shoulders. The anesthesia care provider is always going to be in charge of the head and maintaining the airway. We want to make sure when we are putting the patient into the lateral position that the spine is maintained in the neutral position at all times, which means we need to move them as a single unit. So anesthesia is going to count for us. And on the count of 3, we're going to move, which is the typical scenario. Whenever we are moving a patient, we're going to go on anesthesia's count of 3. Now, the head is typically going to rest on some sort of pad, horseshoe pad or donut or some sort of foam positioning device that has a hole in it, right? So that we avoid pressure on the ear, eye, facial nerves, and the superficial vessels of the face. The eyes are going to be taped to prevent corneal damage. Sometimes the patient is going to be positioned in the lateral using that bean bag or that vac pack. There are also other lateral positioning devices that you will get introduced to in your core classes where we get into our specialty chapters. So you'll see more specific things of that. It is also important to note that the bottom leg is going to be bent to assist in stabilizing the patient, and the top leg is going to remain straight. So if you look at this patient, which probably is not the United States, because you see that metal thing that's underneath the patient's leg, that is actually the grounding device, which we do not use in the United States. So anyways, you can see the little foot peeking out from underneath the pillow. So it's important that we keep that bottom leg bent. The top leg is going to be straight, and then we want to put a bunch of pillows in between, okay? A safety strap is going to be used over the hip, or we're going to use tape. And you can see in this image that they have used tape, and we just go over the patient, under the bed, over the patient, under the bed. And this is very common, actually. If we can avoid taping onto the patient's skin, that would be good. Taping over a blanket or a sheet would be optimal. Sometimes it's not practical, though. The arms. So you can see here how that bottom arm is stretched out and it is supinated, and the top arm is over on another well arm holder and it is pronated. So the bottom arm is going to be palm up and the top arm is going to be palm down. They're going to be padded and secured with straps. The last thing I want to talk about is something called the axillary roll. Now the axillary roll is going to be placed just below the axillary area. You don't want to put it in the armpit, but it's going to go under the patient on their downside, just distal to the axilla. All right, and this is going to help pad that area and decrease the chance for injury of the brachial plexus. All right, the orthopedic table. You might also hear it referred to as the fracture table. It has like 3 million different components and attachments, and a lot of assembly is required. It's a specialty table. It might, if the facility has enough ORs, there may be an OR that is just dedicated to this fracture table. However, I've never worked in a facility where there was a room just dedicated to the orthopedic table or fracture table. It was always shoved in the storage area and the parts and pieces were everywhere, and it was a serious pain to get it in the room, get the other OR table out, get all the positioning devices, and then the surgeon's typically going to come in and help assemble all of these things. Okay, so what do we use this table for? Typically used for hip and other orthopedic procedures of the lower extremities. Hip fractures are common ones, or femur fractures where we're doing some sort of intramedullary nail. I've also seen them for tibial intramedullary nails as well. This allows us to get a circumferential access to that limb. All right, the patient, when they're moved on to the table, it does not look like the image that you see here. There's no post, that's called the perineal post. Let me circle it for you. This that you can see right here is called the perineal post. That is not there. And there is actually a bottom to the bed that extends out like this. All right, all of this stuff is kind of just pushed down into the side. So the patient gets moved over, the patient gets put to sleep, their feet get put into these boots that you see, then the perineal post gets inserted. We want to make sure that we pad it really well so that there isn't any damage to the perineum. Now the book says the perineal area and genital structures must not rest against the center post. I would say that this is almost nearly impossible because they are going to put traction on whatever leg they are working on, and that perineal post is what's going to keep them from falling off the table in all actuality. They are probably very sore in their groin area when they wake up, honestly. So after the legs are put into these boots and the perineal post is there, then the bottom of the table is going to get removed, and this is going to allow X-ray to also come in and give us our A and P and our lateral views, which is going to be really nice. We want to make sure that the arms are either extended on arm boards, they may be folded over the chest, but we want to take care not to extend them too much if they are out on arm boards, and make sure that we pad them well. Because a lot of the patient is going to be exposed to the environment of the OR, they may use a forced air warming blanket on the patient's upper body. Now, at least 4 people are needed for positioning when manipulating this table. It is kind of a big job. But I have a couple more pictures for you on the next slide, so let's take a peek at that. Okay, so here we are. This top image, that's the real deal. You can see the well leg is lifted up and out of the way, and that's the side that the fluoroscopy is typically going to come in on, because now the other part of the story is in the bottom picture. So you see here how they're putting up this big isolation drape. We typically refer to this as the shower curtain drape. And you can't see it, but there's an IV pole here. I'm just going to draw that. And there's an IV pole here. And the IV pole has these little loops. I can't draw with this mouse. But then we put another rod going across this way. And that shower curtain drape is going to go up over the rod. It has a little adhesive strip, and it's going to get stuck to itself on the other side. And on this side, we're sterile. On the other side, not sterile. That's where our fluoroscopy is going to come in from. They have to be really careful not to hit this well leg. But this gives you a little bit better idea of what it looks like in the real world. Now we're going to talk about the prone position. So the prone position provides exposure to the perianal region, the buttocks, the posterior spine, and the posterior lower legs. 4 to 6 people are typically required for this position. And what is going to happen is the anesthesia care provider will put the patient to sleep, which is called induction. So they'll induce the patient on the gurney and go ahead and intubate and secure the tube. And then the team is going to log roll the patient over onto the OR table. All right. This can cause some physiological complications, right? Because the patient is laying on their abdomen and their chest. So this can restrict normal ventilation. There's also additional increased risk of injury to the eyes and the neck. Now, when we log roll the patient, anesthesia is going to be at the head. Someone's going to be at the feet, and it's nice if we have 2 people on either side. This is going to allow us to maintain the spine in a neutral position, as well as protect and manage the airway. Once the patient is over onto their abdomen, you can see how the arm boards are positioned here, and the gel pillow pad that they're using is a special one that rests the forehead and the chin so that there's no pressure on the eyes. There are gel rolls, or what we call chest rolls, that extend from the axilla to the iliac crest. And then there's some padding that goes under the feet so that the toes aren't pressing down on the OR table. All right. Now, some considerations for the female patient. We want to make sure that the breasts are positioned within the hollow that is formed by the 2 lateral chest rolls. If it is a male, we want to make sure that the genitalia is positioned on the midline in such a way that there is no impingement or pressure from the table or other padding or positioning accessories. Again, the patient is placed face down in the hollow centered foam rest or gel rest, and this is to protect the eyes, ears, and facial nerves from injury. Now here is a modified prone position called the jackknife or the Kraske position. And So we're going to take all of the safety precautions that we just talked about with the prone position. The patient is going to be induced and intubated on the gurney. Then they're going to be log rolled into the prone position, and then the head of the bed is going to be lowered and the bottom of the bed is going to be lowered. And this position is typically used to gain access to the anorectal area for like rectal prolapse or hemorrhoidectomy are two common ones. And a lot of the times what they will do is they will tape each side of the buttocks open so that the area that we're going to work on is exposed. Now we want to make sure that there's proper padding at the hip and groin, as well as the head and the feet, so that the toes aren't resting on the OR table like we talked about before. Now, I had a really bad experience with the Kraske position. We had a patient, his name was Frank, and Frank was a very obese individual. He was having a hemorrhoidectomy. He had several comorbidities, and so anesthesia, the surgeon, the patient decided that a spinal anesthetic was going to be best for Frank so that he didn't have to be subjected to general anesthetics. And so the spinal anesthetic was given, and then he was put into position. He positioned himself on the table prone because it was soon enough after the spinal that he could still move himself and position himself comfortably. And then the top of the bed went down, the bottom of the bed went down, so he was in this Kraske position. After a few minutes into the surgery, when the anesthesia care provider was asking Frank if he was okay, Frank wasn't responding. Well, what happened, and what sometimes does happen, if there's not enough time for the spinal anesthetic to settle and take up shop at the level where it was given, because we put Frank in head down, feet down, but specifically the head down, the spinal anesthetic traveled higher than was planned or expected and ended up paralyzing his diaphragm. So Frank wasn't breathing. So we had to stop surgery, roll Frank over onto his back, and anesthesia had to go ahead and do an emergency intubation, and then Frank went to ICU, where he sustained severe brain damage because he had been without oxygen for a while. So these are some things that, although it's not technically inside our scope, we just want to have an increased awareness of what is going on with our patient as much as we possibly can so that we can alert other individuals in the room, whether it's the surgeon or the nurse or the anesthesia care provider, that there is something that is amiss with the patient. And then lastly, we're going to talk about the spinal table. Now we can use the regular OR table with some padding to put the patient in the prone position, as we've talked about before, and do some work on their spine, posterior spine. However, there are a variety of spinal tables as well, and you can see 3 of them here. Same thing we want to think about when we are putting a patient on the spinal table as we do when we are putting them in the prone position. We want to make sure that bony prominences are padded, that the feet are padded, that they're in the safest, most comfortable position possible. The head is going to be positioned on a headrest similar to prone. And it would be nice if we had approximately 6 people to do this. Again, there's going to be some pre-planning before the patient comes in. They're going to get anesthetized and intubated on the gurney and then log rolled onto the table and gently moved into the position depending on which type of spinal positioning device is being used. Again, we want to make sure that for the female that the breasts are not being impinged by any of the positioning devices and that the male genitalia is not being impinged on any of the devices as well. The lower body, depending on what type of positioner is going to be used, is resting on the OR table or whatever positioning device is being used at the time. All right, and then we want to make sure that the toes are free, that they are not resting on the OR table. So if you see the image to the far left, that individual's toes are laying on the OR table. Best practice would be to put some padding or some pillows underneath the lower legs, and that way the toes wouldn't be pushing down against the OR table. It looks like the toes look good on the other two images. So this is the spine table. There can be a specific table just devoted to spine, or there can be a positioning device that goes on the existing OR table, which is what I'm familiar with. So that is that. All right, so that brings us to the end of our discussion regarding moving, handling, and positioning of the surgical patient. So I hope you found it helpful, and I look forward to answering any questions you have in class.